So now we move for the next talk, and which is the skin is also one of the indicator for various rare disease. And Dr. Suman Patra is here. Dr. Abhishek and Dr. Suman Patra, they will be presenting their experience of Geno-dermatoses, which are indicator of a rare disease. And I think this is a very major chunk where we can diagnose these conditions.
Thank you, sir. Good afternoon, all. After the lunch, it becomes slightly difficult to maintain attention. But at the outset, we thank Professor Kuldeep Singh, sir, for giving us the opportunity of speaking on this forum. We see in Rajasthan a number of Geno-dermatoses, which by virtue of, I mean, what is a rare disease is still a definition which is not concluded. We go by one in 2000. A number of these, as sir rightly pointed out, are Geno-dermatoses, a clinic which is run every Wednesday by Dr. Suman. And we have made a collection of primarily the cases that have turned up in the clinic and over to him. But with a request, especially with people coming from Delhi, we have had at least a couple of families who talk about whether we can get a disability certification or some benefit, which unfortunately we have not been able to give to them. There is some development. I was just, while sitting here, I realized that 3 diseases are now being considered to be included in the list of 63. And I think a couple of them are there in the presentation. Over to my colleague, Dr. Suman.
Thank you. Okay, very welcome everyone. So I will be discussing the cases that primarily present to dermatology, and we have a Geno-dermatoses clinic, and all patients are, we see in collaboration with Department of Medical Genetics. Most of the patients are seen by both the clinics. The diagnoses are made. So the role of skin is to early diagnosis of various disorders. Has some skin finding along with have many systemic manifestations. They are sometimes very life-threatening also. There are few pure dermatological rare diseases that has significant morbidity in those patients. So after when I thought I will present this, I was looking for the areas. We have a huge number of cases of Geno-dermatoses, but there is not, the symptoms or signs are so variable across the spectrum. So the clues are not, the diagnosis in the skin, but there is no specific clue in the skin that for that we can say we are dealing with Geno-dermatoses. But there should be, usually these are early onset and they have positive family history many times, but the lesions are variable. So we will be discussing today for the juniors the dermatological clues to diagnosis and the scope for management. That what we are failing. Now we are doing few investigations to prove them, but management wise we are not doing enough, I think. So this is something that it is common in dermatology diagnosis. So this is very early age, immediately after birth, scaling and erythema. So these are ichthyosis group, right? So they had a lot of complications, including vitamin D deficiency, lot of chance of infection, malnutrition. If they survive, sometimes usually currently we have retinoids. So with that, in adulthood they still persist with a less severity. So this these two all are autosomal recessive congenital ichthyosis. Due to there various mutations have been diagnosed like APCA and LOX. So we are to do early diagnosis of disease, and the retinoids is not that cheap. The patient has to take retinoids for a long time, maybe 10 years, 20 years. So that the cost of therapy is very difficult to afford for the patients. And the interleukin-17 inhibitors has been found to be promising in ARCI and Netherton syndrome. And this is costly. So we are trying one of our patients, but I think this is one promise in management of ichthyosis. This is another patient of ichthyosis. Now we can see that apart from ichthyosis, that patient has few more findings, like his abdomen is distended, face is puffy. So this is a common in ichthyosis in peripherally, and it is diagnosed as psoriasis and given topical steroids and oral steroids of various doses. The patient developed exogenous Cushing's. So this is one of those that patient. This patient then When he saw, then we talked to the genetics department, and this patient has hepatosplenomegaly, some corneal clouding, and it was diagnosed with cyanide disease, neutral storage disease. So this is a syndromic ichthyosis. So ichthyosis can be only dermatology related, can be syndromic ichthyosis. This patient has various neurological, ocular, and other systemic abnormality also. So this the dietary modification of omission of fatty acid is another way of managing it, and oral retinoid. So these are the disease of this spectrum. Now come to another spectrum that is commonly seen. These are blisters. So these are the blistering disease that presents to us very early childhood. So we get called from neonatology or pediatrics. Sometimes patients come to us. There is blisters over the trauma-prone area, like knees, ankles, and there is loss of nails. So there is various types of epidermolysis bullosa. The most severe one are these recessive dystrophic one, which in adulthood has lot of morbidity. Like this poor girl has survived until adulthood. There is so many lesions still. There is scarring over the limbs, the back. So this is a debilitating disease. So currently we are diagnosing is with mostly with the lab support and some genetic diagnosis. And the management of ulcers needs a lot of dressing that are very costly, like occlusive dressings for early healing of ulcers, and topical gene therapy with adenovirus vectors has been found to be on the way that it will come maybe few years to be using dystrophic epidermolysis bullosa. Like the collagen 7 is defective, so that is the this. And recently we came across this. This is one of the common type of, like in Delhi they did screening of normal people. 1 in 163%, one allele is affected, collagen 7 is defective. So there is high chance ki, as India has more in intra-cultural marriages, so this number of dystrophic EB can come much more higher in number in future. We need something for the management of this. Like something related, blistering disease in childhood, but we can see the two families, two brothers have similar disease, but they have photosensitivity in the atrophic skin. The lesions are not that severe, but they have atrophic skin over the icral area along the blisters. They can have lot of stenosis. They can have metastenosis, can be laryngeal stenosis. So mucosal involvement is very severe. And we do antigen mapping. There is absence of staining for kindling. So this is a Kindler syndrome. We have few families here. This is, I think, compared to rest of the India, this part has lot of Kindler, epidermolysis bullosa and Kindler. This group is more common in this part. So we have seen couple of families of Kindler syndrome here. Right. So, and obviously therapeutically we are doing nothing. We can very early diagnosis, we can do that, but still in nasal stage. So now come to another disease. So it is photosensitivity and ulcers and scars. You can see there are scars over the face, very atrophic scars, and the lesions over the knuckles areas. Right. So initially we were thinking about whether it could be Kindler syndrome or something else, or some heterosensitive autoimmune neuropathy, but it was a congenital erythropoietic porphyria. The porphyria is one of the common group of disorders that we see. Not that common, actually rare disease, but a lot of morbidity. They can develop cancers and skin cancers, and this is a less severe one. More severe one is much more morbidity. They are usually we have few patients, the adult, they can only work only at night. They're all work as night watchman or something. There are a lot of hypertrophy. They can't go out in the morning. So one patient I remember in a previous institute that underwent transplant, but the continuous monitoring, continuous behavioral change, like lack of absence of sun exposure, is something important that can be done. So now coming to the different spectrum of disease. So these are diseases that are multi-system disease, but skin can give an important clue for early diagnosis. Like this is a 10-year-old girl, with multiple ulcers. We can see nodules, large ulcers, and center the erythema around it, and recurrent episodes over abdomen and thighs. This is the thigh lesions there. So, but the clues were high TLC. We discussed with the pediatrics professor, and high TLC and a lot of neutrophils. So when pyoderma agnosium like ulcers with high TLC, you suspect leukocyte adhesion deficiency. So it was LAD1. So we do screening for in flow cytometry. It was LAD1. So now we are managing this patient with like anti-inflammatory, like anti-neutrophilic agents. But we are so this, since early childhood we can still plan for stem cell transplantation. So that is, the therapies are still out of reach from us, but we are seeing a lot of cases like this. This is another case. So this is atopic dermatitis is common in childhood, but this is very refractory atopic dermatitis. and recurrent skin infection, fever. Even the last admission was in some previous hospital, and with thrombocytopenia, they diagnosed dengue. He was admitted for 30 days in hospital, but there's recurrent hospital admissions. But then he has impetigo. You can see some hemorrhages here. There persistent thrombocytopenia. It was a Wiskott Aldrich. So this is we said sent I think with the up to corroboration report of pediatrics we sent there. The report came. We are waiting for the genetic report. So Wiskott Aldrich is something that can present with refractory atopic dermatitis and thrombocytopenia. So PID, primary immunodeficiency disorders, are something that has a lot of dermatological manifestation. So this is something you can look at the skin and suspect them that they can have those diseases. So these are other than Wiskott Aldrich, hyper IgE syndrome, hypergammaglobulinemia, and CGD can also have a lot of atopic dermatitis. Like this is one that is you all are familiar with that. This is neurofibromatosis type 1. We can see that is capsular macules, lot of dermal neurofibromas. So they have a lot of mental retardation sometimes, ocular and skeletal abnormality. We can see some musculations here, but this is another variant of this plexiform neurofibroma that has much more pendulous and larger growth, and that it can be function threatening. Sometimes if it is about the spine and other areas, it can alter the function, can be neurological disability. Finally, there is one drug, there is a kinase inhibitor, selumetinib has been approved, has been used in plexiform neurofibroma as off-label, and there are the NEGM article shows significant improvement with selumetinib. So I think last year we have a discussion on that in one of the CMEs. So this is something we can use, but this is very costly. We tried, but so it is still not in a rare disease, not included in that, so we're not able to procure that. But this is one promising therapy, most of all function threatening plexiform neurofibroma. This is another disease that come to dermatology OPD with a lot of this small red, cherry red like papules, and the patient has pain over the limbs, and you can close inspection, you can see there vascular lesions, small red dots. So they in dermatology you can think of angiokeratoma. So angiokeratomas over the budding shoot areas, like the areas over the lower trunk and upper thighs, it's called angiokeratoma corporis diffusum. So this is Fabry's disease. So alpha galactoside level is low in blood. So this is the case of Fabry's disease. So early diagnosis with fitness finding can be done. And in this case, enzyme replacement therapy is helpful when it's done early. Many of the neurological findings can be irreversible. So the early diagnosis is very important in those disorders with skin disease also. So yeah, so now we are thinking what we can do more. Like so early diagnosis is important. Genetic diagnosis we are sending outside. So in-house NGS facilities say the need that we can, if we can do that, a lot of patients can be benefited. Treatment is difficult and lifelong, so cost of treatment is high, and even the transplants should be done early in life. So I thank my department and Department of Pediatrics for that.